Good morning, students. So today's topic of our lecture is chronic bronchitis. What is bronchitis? Bronchitis is inflammation of the bronchi. It might be large and medium-sized airways in the lungs. For symptoms, you can have a look at coughing up mucus, wheezing, shortness of breath, and chest discomfort. Bronchitis is divided into two types, acute and chronic. Acute bronchitis is also known as chest cold. What is chronic bronchitis? Chronic bronchitis is defined as a condition associated with excessive tracheobronchial mucus production to cause cough with expectation for at least 3 months of the year for more than 2 consecutive years. Chronic bronchitis causes excessive amounts of sticky mucus to build up in the airways, restricting amount of air flows in and out of the lungs. You can have a look at chronic bronchitis. Here, this is healthy, and this is inflammation of excess mucus. This is normal airways and airways in bronchitis, which can be swelled, filled with mucus, and restricted airflows. Incidence: middle and late adult life, more in males than females, more in smokers than in non-smokers, more in urban than in rural dwellers. Risk factors: smoking, occupational hazards as with exposure dust, smoke, and fumes, worker in cotton mills, worker in plastic industry, for air pollution, dust, air pollution, coal, and biomass fuels, low socioeconomic status, previous tuberculosis, familial and genetic factors, infection with rhinovirus, strep pneumonia, H influenza A and B, weakened human immune system, chemical inhalants, COPD, pathogenesis, increase size of mucus gland in the wall of bronchial tree, increased size of viscid mucus, which may result in obstruction of the bronchial tree, edema, and increased cellular infiltration of airways wall, narrowing of respiratory airways. Pathogenesis: continuous irritation by smokes, SO2 or infection, hyperplasia and hypertrophy in the mucus gland, airway obstruction, and leading to emphysema. Pathological changes. Hypertrophy and hyperplasia of the mucus producing gland, goblet cell hyperplasia, re-education in ciliated cells, mucosal edema and intraluminal mucus plug, increased smooth muscle, reduction in the caliber of the air passages. Here is the clinical type. Simple chronic bronchitis. Patients have a productive cough but no physiologic evidence of airflow obstruction. Asthmatic chronic bronchitis in individuals demonstrating hyperreactive airways with intermittent bronchospasm and wheezing. Obstructive chronic bronchitis in some patients, especially very heavy smokers who develop evidence of associated emphysema. Its symptoms include cough with sputum production, shortness of breath, wheezing, tightness of chest, fatigue, coughing with chest pain, cyanosis, slight fever and chills, weakness, body ache. Some common signs and symptoms of bronchitis are sore throat, fatigue, stuffy or runny nose, fever, body ache, vomiting, diarrhea. Diagnosis include physical examination, sputum test, pulmonary function test, chest X-ray, chest CT, and ECG. Usually, the patient is overweight. At rest, there is no respiratory distress. Respiratory rate is normal, normally resonant over the lungs. Liver dullness and cardiac dullness are normal in position. Auscultation to vascular breath sounds with prolonged expiration, inspiratory and expiratory bronchi. Repetitions, changes in location and intensity after coughing. Sputum test. Mucus curved up from the lungs to be tested on analyzing presence of bacteria. Pulmonary function tests, spirometry, FEV1 reduced, FEC decreased, ratio of FEV1, FEC subnormal, PEF reduced, RV increased, FRC increased, and TLC also increased. And now here is the picture. You can see what to expect during the spirometer test. The first thing you can expect is height and weight measure. Second, nose is clipped to encourage mouth breathing. Blow into mouth is connected to spirometer, repeat 3 times, and for the spirometer creates graph of lung functions. Here you can have a look at the chest X-ray. This is chronic bronchitis and the illness that leaves the right tail horizontally, shows irregular borders because of chronic inflammation. This shows irregular pattern, bronchovascular structure, thickening of bronchial wall. It may show signs of inflammation and bronchi. This is ECG of bronchitis patient. ECG may show features of right atrial and ventricular hypertrophy. Tall PVs are PV. Here are the differential diagnosis. There might be asthma, pneumonia, emphysema, and allergic rhinitis. This is differential diagnosis between chronic bronchitis and bronchial asthma. Age in chronic bronchitis is usually adults. It generally happens in adults, and in bronchial asthma, it can happen at any age. Smoking history in chronic bronchitis almost invariable, and bronchial asthma it's possible. Chronic bronchitis, cough history, persistent and productive, and in bronchial asthma, intermittent and non-productive. In chronic bronchitis, breathlessness is persistent, and bronchial asthma, intermittent. In chronic bronchitis, nocturnal symptoms are uncommon, and in bronchial asthma, they are common. In chronic bronchitis, family history is uncommon unless family members smoke, and in bronchial asthma, family history is common. In chronic bronchitis, other allergic diseases are uncommon, and in bronchial asthma, they are common. In chronic bronchitis, airflow obstruction is irreversible, and in bronchial asthma, they are reversible. In chronic bronchitis, sputum, macrophages, neutrophils, corolla bodies, and in bronchial asthma, eosinophils, Charcot, Gershman spirals, Crayola bodies. These are the complications: respiratory failure, pulmonary hypertension, carbon dioxide necrosis, and secondary polycythemia. The management are regular exercise and nutritional management, stop smoking completely, use of nicotine, replacement therapy by gum, transdermal patching, varenicline, which is nicotine acetylcholine receptor partial agonist, and bronchodilator inhalation of beta-2 adrenoreceptor agonist like salbutamol 200 micrograms or terbutaline 500 micrograms, inhaled corticosteroids. The management are oxygen therapy through nasal cannula, and symptomatic measures may include hot rings or steam inhalation to liquefy sputum. Mucolytic agent includes bromohexane and ambroxol, and chest physiotherapy. Antibiotics include azithromycin, third generation, cephalosporin, and amoxicillin. The preventions are stop smoking, exercise regularly, protect yourself from cold air, getting vaccination to prevent respiratory infection, avoid other respiratory irritants, and wash hands regularly. Thank you.